Hello friends, we are going to discuss about another points of leukemia. So, first of all, in leukemia, Burkitt lymphoma, Burkitt lymphoma, BC. So, CMYC gene. Next is site of involvement, site in Africa or in endemic zone. Africa, it is in mandible. In sporadic region, it is ileocecal. Ileocecal region. So remember this photo or picture. Next, another important point for MCQs. First, gluten sensitive enteropathy. Gluten sensitive enteropathy. Gluten sensitive enteropathy. T. So it is associated with T. T cell lymphoma. T cell lymphoma. So gluten sensitivity enteropathy associated with T cell lymphoma. Next, Clover cells. Clover cells. CA. AC. So adult T cell leukemia. Adult T cell lymphoma or leukemia. Next, Sézary cell. Sézary cell. Seen in peripheral T cell lymphoma. Peripheral T cell lymphoma. Sézary cells. Portier's microabscess. Portier's microabscess are seen in mycosis fungoids. Microabscess, micro. Microabscess, micro. Seen in mycosis fungoids. Next, another important point is anaplastic large cell lymphoma. Anaplastic large cell lymphoma. Anaplastic large cell lymphoma. Embryo cell present. Next, associated with breast implant. Associated with breast implant. Donut cell present. Donut cells presents. So embryo cell, breast cell, donut cell. What is the numeric? A, B, D, E. So anaplastic large cell, breast implant, embryo cell, donut cell, A, B, D, E. This is the mnemonic. Next. Next is multiple myeloma. Next is multiple myeloma. Multiple myeloma. So M. If we erase these two arms, so it is 1 1. So what is the gene translocation here? T1114. What is the gene mutation? Cyclin D1. Here is always also 1. So what is the abnormality of immunoglobulin? IgG. It is M, but most commonly IgG, not IgM. So most commonly IgG, specifically if we say IgG3. So it is L. So most commonly affected vertebra is lumbar vertebra. Lumbar vertebra. So in multiple myeloma, gene translocation is 1114, 1111. Cyclin D1 and the immunoglobulin, abnormal immunoglobulin is IgG, not most commonly not IgM, most commonly is IgG, specifically IgG3, and most affected vertebra is lumbar vertebra. Here is the two important another point is here we can see punched out bony lesion. Punched out bony lesions. Next important point, Baines Jones proteinuria. Baines Jones proteinuria. It is multiple myeloma. Next, in myeloma, we can see CRAB. What is CRAB? C. Calcium increase. So what is the value? 11 milligram per deciliter. R for renal insufficiency. Renal insufficiency. So serum creatinine greater than 2 milligram per deciliter. A for anemia. A for anemia. So hemoglobin less than 10 gram per deciliter. So hemoglobin is less than 10 gram per deciliter. And B for bone. Bony lesion greater than 1 lytic lesion. Greater than 1 lytic lesions. Next. Here we can see two types of cells. What are the two types of cells? Number one, Dutcher body. Dutcher body and Russell body. And Russell body. So in Dutcher, letter is 6. DUT. Sorry. His letter is 7. So here is letters 7. So it is intranuclear or intracytoplasmic? It is intranuclear. Why? It is intranuclear. There is also 7 letters. And Russell body is intracytoplasmic. You can also remember in this way the class representative CR, class representative CR. So Russell body intracytoplasmic, And Duchar body, there is 7 letters. Nuclear, there is also 7 letters. So intranuclear, Duchar body, Russell body, intracytoplasmic. And most powerful prognostic factor in case of multiple myeloma is serum beta 2 microglobulin. So most powerful prognostic factor, most powerful prognostic factor in multiple myeloma is serum beta 2 microglobulin. Serum beta 2 microglobulin. Microglobulin. So the most powerful prognostic factor in multiple myeloma is serum beta 2 microglobulin. Here is the important point in case of multiple myeloma. In multiple myeloma, in multiple myeloma, no bone formation, only bone lysis. No bone formation, only bone lysis. So, in case of multiple myeloma, ALP, alkaline phosphatase, is normal, not raised. So, what is the point? In multiple myeloma, no bone formation, only bone lysis. So, value of ALP, alkaline phosphatase, is normal, not raised. But ESR, erythrocyte sedimentation rate, increased. Next, we are going to discuss Waldenstone macroglobulinemia. Macroglobulinemia. Waldenstone macroglobulinemia. Here is two important point. First is it is associated with hepatitis C and associated with hyperviscosity. 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 Hepatitis C, hyperviscosity. And here we can see recurrent infection. Next, epistaxis. Next, visual disturbances. And fatigue. So, Waldenstrom macroglobulinemia associated with hepatitis C, associated with hyperviscosity. In Waldenstrom macroglobulinemia, we can see recurrent infection, epistaxis, visual disturbances, and fatigue. And it is also called hyperviscosity syndrome. It is also called hyperviscosity syndrome. Also called hyperviscosity syndrome. Next is Hodgkin's lymphoma. Next is Hodgkin lymphoma. Hodgkin lymphoma. So next is Hodgkin lymphoma. Some important points in Hodgkin lymphoma. It is painful with alcohol ingestion. It is painful with alcohol ingestion. It is painful with alcohol ingestion. Very important point. Painful with alcohol ingestion. And there is, you can see some cells like lacunar cells and popcorn cell. Lacunar cells and popcorn cell. Here is the pictures. Lacunar cells and popcorn cells. Next, subtypes of Hodgkin lymphoma. Mainly we should remember three or four subtypes. First, first is mixed cellularity. Mixed cellularity. Mixed, so mixed is most common in India. Mixed is most common in India. It is important point. Next, nodular sclerosis. Nodular sclerosis. Here we can see lacunar cells. Here we can see lacunar cells. 3. Lymphocyte predominance. Lymphocyte predominance. So here lymphocyte is present or dominantly present. So it has best prognosis. Best prognosis among other types of Hodgkin lymphoma or among other subtypes of Hodgkin lymphoma. It is the best prognosis. And here we can see popcorn cell. Here we can see popcorn cell. Another is lymphocyte depletion. Another is lymphocyte depletion. So lymphocyte almost depleted, almost finished. So it is poorest prognosis. It is poorest prognosis. And so here we can see opportunistic infections like HIV present and Epstein-Barr virus present maximum. So what are the subtypes of Hodgkin lymphoma? Different subtypes of Hodgkin lymphoma. First, mixed cellularity, most common seen in India. Nodular sclerosis. Nodular sclerosis. It is lacunar cells. Next, lymphocyte predominance. So lymphocyte predominance means lymphocyte presence predominantly, mostly lymphocyte presence. So it's the best prognosis cause lymphocytes protects. And here you can see popcorn. Just imagine in a relaxed condition we are taking popcorns in movie hall, so we are protected. We are happy. Like this popcorn cells. In relaxed condition we can eating popcorns. So lymphocyte predominance cause we are protected. Lymphocyte presence, so it has best prognosis. And then lymphocyte depletion. Lymphocyte depletion means less amount lymphocytes, so it has poorest prognosis. And in case of lymphocyte depletions, there are opportunistic infections like HIV positive Epstein-Barr virus present. Next, clinical staging of Hodgkin lymphoma or non-Hodgkin lymphoma. So, what is the classification? And Arbor classification. And Arbor classification. And Arbor classification. There is 4 staging. First, single lymph node origin. Single single lymph node origin. Next, two or more lymph node but in same side of diaphragm. Two or more lymph node origin but same side of diaphragm. Same side of diaphragm. It is same, but it is both side of diaphragm. Both side of it is one or more extra lymphatic organs. One or more extra lymphatic organs. So, what is the grading and Arbor classification? Grade one or more lymph node origin. It is not important. We get MCQs from these two. Always remember in NEET PG when one asks questions from classification, they try to ask questions from mid mid position or mid portion of the classification, not from first or not from very last. So these two are important. Two or three. Two grade two means two or more lymph node origin, but same side of diaphragm. But same side of means above the diaphragm or below the diaphragm. Means same side above or below the diaphragm. But three both side of diaphragm. Three is both side of diaphragm. And four one or more extra lymphatic organs. One or more extra lymphatic organs. Next. Next important point is we can see pond ball megakaryocytes. Pond ball megakaryocyte. Pond ball megakaryocyte in myelodysplastic syndrome. In myelodysplastic syndrome. Here is a picture. This is called pond ball megakaryocyte seen in myelodysplastic syndrome. Next, is CML, chronic myelogenous leukemia. CML, chronic myelogenous leukemia. Here is the gene ABL and BCR. A comes first, B then. So it is 9Q and it is 11, 22Q. So A comes first, so 9, B comes second later, it is a second later, so 22Q. And what is the gene translocation? T922, Q34, Q11. How we can remember it? 11, 22. 11 is 2 equals to 22. So it comes here. So T922, Q34, 11. Yes, we can remember it like that way. It is Philadelphia chromosome. So it is Philadelphia chromosome. Philadelphia chromosome. So it is a Philadelphia chromosome. And it is a catch point in CML that in CML we can see massive, massive splenomegaly. We can see massive splenomegaly. It is a very important point for NEET PG. In CML, we can see massive splenomegaly. And there is another point in CML, we can see pseudo-Gaucher cells. Pseudo-Gaucher cells associated with CML, associated with CML. And what is the gene translocations जो BCR-ABL gene translocation, BCR-ABL gene translocation. Translocation activates tyrosine kinase. Activates tyrosine kinase. So what is the treatment of CML? What is the treatment of the CML? Treatment of CML is tyrosine kinase inhibitor. Tyrosine kinase inhibitor. What is this? Imatinib. Imatinib. So treatment of CML is tyrosine kinase inhibitor, imatinib. So in CML, we can see massive splenomegaly, pseudo-Gaucher cells associated with CML, and BCR-ABL gene translocation activates tyrosine kinase. Treatment of CML, tyrosine kinase inhibitor is imatinib. There is another MCQs. ALP, low LAP scores. What is the full form of LAP? Leukocyte alkaline phosphatase. Leukocyte alkaline phosphatase. It's a very important question, many times asked in NEET PG. What is low LAP scores? LAP has got 3 letters. So CML, MDS, PNH, and SCA. So CML, chronic myelogenous leukemia, every has got 3 letters. So there is a 3 letters, 3 letters. What is the full form? CML, chronic myelogenous leukemia. MDS, myelodysplastic syndrome. Myelodysplastic syndrome. SCA, sickle cell anemia. PNH, paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria. Hemoglobinuria. So how you can remember is low LAP score? Low LAP score, LAP means leukocyte alkaline phosphatase. So low LAP score, this is has LAP has got 3 letters. So in we should remember low LAP scores. Then we can rule out high LAP score. We should not, or we don't need to remember high LAP score. We do not need to remember high LAP score. If we remember low LAP score, we can easily rule out the high LAP scores. So it has 3 values. CML has 3 letters, MD has 3 letters, PN has 3 letters, SCA 3 letters. Sickle cell anemia got 3 letters. Next, Next is essential thrombocytosis or essential thrombocythemia. Essential essential thrombocythemia. Thrombocythemia. Essential thrombocythemia or primary thrombocytosis. Primary thrombocytosis. Thrombocytosis. Here we can see platelet increase in size and shape with abnormal function. So platelet increase in size and shape with abnormal function. Then it causes microvascular occlusion. Microvascular occlusion. It causes TIA, transient ischemic attacks. Transient ischemic attacks. So microvascular occlusion causes transient ischemic attacks. Why? Now platelet increase in size and shape with abnormal function, and it causes essential thrombocythemia. Essential thrombocythemia. And there is an important MCQ. In case, just imagine there is an MCQ, history of polycythemia. History of polycythemia. Ascites, liver enlargement means hepatomegaly. Hepatomegaly. History of polycythemia means increase WBC platelet, decrease hemoglobin. What is the cause? Most common cause is Budd-Chiari syndrome. Budd-Chiari syndrome. So, how you can remember it? Budd-Chiari syndrome mainly affects caudate lobe of liver. Mainly affect caudate lobe of liver. So, A. Ascites, B. Budd-Chiari syndrome, caudate lobe, hepatomegaly, and polycythemia. So, BC, it is BC, Budd-Chiari caudate lobe. There is a ascites, hepatomegaly, caudate lobe enlargement, lobe of liver enlargement. So it is caused hepatomegaly. So it's caused hepatomegaly. There is a BC. BC means Budd-Chiari syndrome, affects caudate lobe of liver, caudate lobe of liver enlargement. So it's caused hepatomegaly. And ascites, history of polycythemia present. So it is Budd-Chiari syndrome. So it is Budd-Chiari syndrome. And there is another syndrome. There is another syndrome. It's called Felty syndrome. Felty syndrome. Here is rheumatoid arthritis, splenomegaly, and neutropenia. Neutropenia. So rheumatoid arthritis, splenomegaly, and neutropenia, triad of Felty syndrome. Felty syndrome. Here we have missed a point in thrombocythemia. Missed a point is thrombocythemia. So, what is the drug of choice for essential thrombocythemia? What is the drug of choice for essential thrombocythemia? Hydroxyurea. It is a very important MCQ. What is the drug of choice for essential thrombocythemia? It is hydroxyurea. What is the drug of choice for essential thrombocythemia or primary thrombocytosis is hydroxyurea. Always remember it. Next, next is polycythemia vera. Is polycythemia vera. Polycythemia vera. In polycythemia vera, we can see JAK2 mutation, V617F mutation. We can see JAK2 V617F mutation. And clinical feature we commonly seen pruritus. We can see pruritus. It is due to JAK2 mutation. It is due to JAK2. It is due to JAK2 mutation. It is due to JAK2 mutation. We can see pruritus in polycythemia vera. What is the diagnostic criteria for polycythemia vera? What is the diagnostic criteria for polycythemia vera? Here, first of all, hemoglobin. Hemoglobin should be greater in 16.5 in men, greater than 16 in women. First, second, JAK2 mutation, JAK2 mutation. 3 and panmylosis. Panmylosis. What is panmylosis? Panmylosis means increased WBC, increased platelet. So in this case, hemoglobin less than 6.5, greater than 6.5, greater than 16, JAK2 mutation, panmylosis. All three major criteria or first two major criteria, and one minor criteria is low serum erythropoietin level. Low serum erythropoietin level. So what is the important point in case of polycythemia vera? Look at the point. For diagnosis of polycythemia vera, hemoglobin should be greater than 16.5 in men, greater than 16 in women. JAK2 mutation and panmylosis, increased WBC, increased platelet. It is a major criteria. These are major criteria. So it should be three major criteria or first two major plus one minor criteria. Plus one minor criteria. What is minor criteria? Low serum erythropoietin level. It is a very important MCQ. In polycythemia vera, we get low serum erythropoietin level. In polycythemia vera, we get low serum erythropoietin level. Next is Langerhans cell histiocytosis. Langerhans cell histiocytosis. histiocytosis. Langerhans cell histiocytosis. What is the normal function of Langerhans cells? It is A, B, C. Antigen presenting cell. It is antigen presenting cell. It's Langerhans cell histiocytosis. Antigen presenting cell. In electron microscope, we see some points. First, it shows Barbic granules. Barbic granules. Tennis racket appearance. Tennis racket appearance. Tennis racket appearance. Barbie granules or tennis racket appearance. Next, what is the marker? Immunohistochemistry CD1A. CD1A is immunohistochemistry marker. In electron microscope, we can see Barbie granule or tennis racket. Electron microscope. In electron microscope, we can see Barbie granules or tennis racket appearance. In immunohistochemistry, CD1 is a marker and it got coffee bean shaped nuclei. Here, coffee bean shaped nuclei present. 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 And in Langerhans cell histiocytosis, we can get Langerhans. In Langerhans cell histiocytosis, we can saw vertebra plana. Next, floating teeth sign. Floating teeth sign. Next, large premature lesion. Large primitive lesion. Large primitive lesions. So in Langerhans cell histiocytosis, we can see vertebra plana, floating teeth sign, large primitive lesions. Large primitive lesions. Here is the MCQ. Where is the MCQ? In MCQ, enlarging scalp lesion. Enlarging scalp lesion. No history of trauma to the head or scalp. The child is otherwise healthy and investigations are normal. Investigations are normal. And in so think about LCH. Think about LCH. Why? In LCH, skull is most commonly involved site. Skull most commonly involved site. Skull most commonly involved site in LCH. It is MCQ from Marrow. Enlarging scalp lesions, no history of trauma to the head or scalp. The child is otherwise healthy and investigations are normal. Think about LCH, Langerhans cell histiocytosis. Langerhans cell histiocytosis. And we have missed one or two MCQs previously. First, treatment of polycythemia vera. Treatment of polycythemia vera. What is the treatment of polycythemia vera? Is rituximab. Sorry, ruxolitinib. Ruxolitinib. JAK2 inhibitor. JAK2 inhibitor. So treatment of polycythemia vera is ruxolitinib JAK2 inhibitor. So treatment of polycythemia vera is JAK2 inhibitor, ruxolitinib. Ruxolitinib. And in case of multiple myeloma, we can see a MOTS cell. In case of multiple myeloma, we can see MOTS cells. In case of multiple myeloma, we see MM, so we see MOT cells. Here is a picture. It is called MOT cells. In multiple myeloma, we can see MOT cells. And that's all.